Hello there.
Morning.
May I examine your heart?
Yes.
Great. So if you just lie where you are, I'm going to uncover you to start with, if that's all right.
Yes.
Good. And just rest your head back there. Okay. Would you mind stretching your arms out for me? I just want to look at your hands. That's great. Pop that down. Great. And rest your arm back down there. I'm going to check your pulse now. Okay. I'd like to lift your arm up and assess your pulse again. Have you got any pain in your shoulder or your elbow at all?
No.
Okay. Rest your head back again. That's great. Okay. Now, would you mind turning your face towards the wall? Just look towards the wall. Chin up a little bit. Okay, you can look where you like now. Now, again, a bit of pressure from my fingers just on your chest there. And then a little bit of pressure across your chest. You seem a little bit short of breath. Are you all right?
Yes, I'm fine.
Good. Okay. I'm just going to grab my stethoscope. Okay, can I ask you to roll onto your left side for me? That's great. And rest your arm on there. Perfect. That's great. And if you sit forward for me now. Okay. That's great. Now when I ask you to, I'd like you to breathe in and stop, and then breathe out and stop. Carry on breathing normally until I ask you to. Breathe in, stop there, breathe out, and stop there. Breathe away, lift your chin up for me, a little bit of pressure on the side of your neck now, and on the other side. Okay, I'm going to listen to your chest now. Just lean forward for me. Take some deep breaths for me, in and out through your mouth. That's great. Lie back for me now. When asked to examine a patient's heart or examine their cardiovascular system, it's important to make an overall assessment of the patient to start with. Assess whether they're comfortable at rest. And in this lady's case, she appears to be slightly short of breath just from the effort of walking onto the examination couch. Note that, make sure they're comfortable, and then expose the body parts as you need to as you go on. As with all cardiovascular examinations, start from the periphery and work centrally. So I started by looking for any signs of infective endocarditis, splinter hemorrhages, looking for clubbing, etc. And then checking her pulse. The radial pulse is assessed for rate and regularity, and the central pulses are assessed for character. Again, once you get to her chest, you should follow the sequence of palpating, percussing where appropriate, and then auscultating. And as you go along, develop an idea of a differential diagnosis. In this lady's case, the salient features are that she has a regular pulse and she has quite a clearly audible ejection systolic murmur heard at the left sternal edge. In expiration while sitting forward, she also has an early diastolic murmur. Her pulse character is normal. All of these features are consistent with mixed aortic valve disease. You should also pick up signs of how important this mixed aortic valve disease is for the patient and for the patient's heart. Is there evidence of cardiac failure or cardiac decompensation? What's the second character of the second heart sound? These are all important features to pick up. Incidentally, this lady also has quite a wheezy chest and has some features of obstructive airways disease, so it may not necessarily be limited to one pathology. This lady has the classical signs of mixed aortic valve disease. She has an ejection systolic murmur, best heard at the left sternal edge, but audible throughout the precordium, as well as an early diastolic murmur, which is best heard sitting forward in expiration. Her second heart sound is quiet, consistent with the aortic stenosis being the predominant lesion and being of at least moderate severity, and this is corroborated by a slow rising pulse. There are no features of cardiac enlargement or cardiac decompensation. Incidentally, this lady also has the clinical findings of obstructive airways disease. In a typical examination scenario, you should expose the patient at least from waist right to their heads. For the purpose of this tape, as we're filming, this lady had only undressed down to her underwear. It's also important to complete your cardiovascular examination by looking for evidence of peripheral edema, examining the abdomen to look for hepatomegaly, which may or may not be pulsatile, which we did not go on to do during that demonstration. In aortic valve disease, it's important to document not only the murmur, which is what most people first talk about, but the intensity of the heart sounds, which give you a lot of information about the severity of the underlying lesion. Severe aortic stenosis is characterized by a quiet second heart sound and a slow rising pulse. Similarly, aortic regurgitation, when severe, is characterized again by a quiet second heart sound, and in this case a collapsing pulse. It's important to remember that the intensity of the murmur, the amplitude of the murmur, has no bearing on the severity of the underlying hemodynamic lesion. When presenting your findings, you should take your thoughts a step further and think about the factors that might help you in managing this patient, in perhaps deciding when to send the patient ahead for surgical valve replacement. And those features would obviously in real life depend on symptoms, but any evidence of cardiac decompensation would press you to pursue a surgical strategy as well.